Well, hello, everybody. Good afternoon or good morning, depending on where you are in the country. My name is Garrett Schmidt, and I'm the managing editor for VBC Exhibit Hall. And I'd like to welcome you all to today's live webinar hosted by Roji Health Intelligence. Today's session is the first of a three-part series, and it is called Your ACO Guide to Targeting Cost with Data-Driven Strategies. And so this is part one is focusing on best strategies with easily available data. So very excited to hear about this. I think you're going to have a lot of great takeaways and some really good stuff to study later. That said, a couple housekeeping items before we get started. Everyone has joined today in listen-only mode. This is a traditional webinar format, so we can't see you or hear you. But as I always say, we do want to hear from you. We're going to have a time for Q&A towards the end, where we'll be able to take questions from the audience and answer as many questions as we can. If we don't get to yours for some reason during the allotted time, then someone will reach out to you afterwards with an answer. So please, even if we're wrapping up at the last second, go ahead and drop your question in there. And you'll see there's a little question module, which is different than the chat. So go ahead and use that if you want to ask a question. You don't have to wait until the Q&A to do it. Just go ahead and do that at any time. And then finally, today's session is being recorded. And so what's going to happen is when we're done, you'll receive an email about an hour or so afterwards that will have a link to the recording and also where you can download the slides and read a little bit more about Roji, and there'll be some other resources there for you as well. So without further ado, I wanted to introduce our host today, Miss Terry Hush, and she's the CEO and founder of Roji Health. So welcome, Terry.
Thanks so much, Garrett, and hi, everybody. I hope it's going to be an info-packed session for you today. A lot of content to present, and I hope for some really good questions at the end. And what we're going to talk about is about how you can target. You'll see a lot of pictures of targets in this presentation today, how you can target costs with data-driven strategies. A little bit about us. The important thing to take away from all these words is that we are both in the quality end and the cost end of the value-based care technology and services segment. All of our clients are providers, and we are helping them identify patients at risk and targeting interventions. So who's going to get the most out of this today? Well, certainly ACOs evaluating how they can address affordability, excuse me, a little bit of frog in my throat today, and improve their savings. So this is about ratcheting up the savings potential for ACOs. ACOs on the path to risk and worried about their sustainability, especially ACOs that are considering the new payment model that's just been announced, should really look at this seriously, because you will really need to make sure that your capitation payments are excessive of your expenditures. And then, of course, the health systems, medical groups, and ACOs that are negotiating contracts with total cost of care or risk features, you're going to need to know how you can break that down into actionable items. So I want to first find out a little bit about your attitudes going into this, and then we'll talk again later and see if they've changed. And the question I have is, what data are you using for cost initiatives? So the answers that you'll be able to choose from in the polling question are: A, we use claims data; B, we aggregate EHR data to use for cost analyses; and C, neither, we don't have a direction yet; or D, this is too complicated, these dogs are too hairy. And I sometimes agree with that. These are my dogs.
Okay, so we have the poll up on the screen now, so you can go ahead and engage. And by the way, these are anonymous, so and we'll show the results, so you'll be able to kind of see where you stack among your colleagues and who else is on the line with us today. And we've got results coming in here, so we'll just give it another couple seconds for folks to choose. And this is a select one that most applies. Okay, I think we've got most of our answers in. So I'll give it a 5 count and then I'll close it down. 5, 4, 3, 2, and 1, and a long one, and then I will end it and share the results. Excuse me, I got the frog too, apparently. Frog is getting around. Okay, so the results, Terry, I don't believe you can see this, right?
No, I can't.
Okay, so the answer for the first one is we use claims data for cost initiatives. That's 76%, the vast majority here. Next is we aggregate EHR data to use for cost analysis. That's 7%. Next is neither is 11%. And then it's too complicated. These dogs are just too hairy is 7%.
Oh, wow. Oh, wow. Very interesting. Well, I just want to point out that on A, we use claims data for cost initiatives. You've just chosen a puppy who is attacking a stick vertically. So I don't know what that tells you about the claims initiative or my impression of using claims initiatives, but we'll get into that. That's one of the subjects for today. So I'm excited to hear it. I'm surprised to hear the low level of EHR data, but I'm not surprised that many are searching for a direction on what kind of data to use. And I guess I'm not too surprised. Nobody would want to deal with these hairy dogs. So, what we'll cover today, we will talk about the total cost of care and total per capita cost because these are the terms that are out there and what that includes. We'll talk about some tricky issues and how you manage costs when what you're being measured by are total cost of care and total per capita cost. Then we'll discuss what you're going to get from a total cost of care reduction and how you can structure a realistic plan of initiatives to get there. What is the easily available data for ACOs for cost reduction? And the hint here is it's not just claims. What claims data contains that could be valuable for cost control, and the pros and cons of a claims only approach. So the first question that I want you to keep in your heads as we go through this is, can your action plan be as simple as reducing total cost of care? And here we see an image of a highway, which should bring in mind some of the events of the last few weeks, skirting a cliff. And the only way that that highway can skirt this cliff is with all those supports that are sitting under it. Your path to total cost of care reduction has to be supported by multiple cost targets and strategies. And let's go into some of the basics of what those are. Basically, there are going to be two questions we're asking. What are your targets? Do you have the information to meet that target? And this is depicted by this karate expert who has no target. Beautiful picture, no target. Total cost of care, total per capita cost is how payers and patients are measuring your affordability. But many of them are also tracking individual cost targets within that. For example, those that we already know, the risk standardized all condition readmissions and unplanned admissions for people with chronic disease. Sorry for the typo. CMS value-based quality programs are also using what they cast as a quality measure, but are really a cost measure within that. So that's an important thing to recognize. Cost measures aren't only in a separate segment called cost. Total per capita cost is the goal of value-based payment models with capitation. You see it in ACO REACH, you see it in Medicare Advantage models on a more frequent basis than ever before. Most of them are moving to capitated models right now. We're seeing it in the specialty care models like enhancing oncology, and we will be seeing it in the MSSP program if a lot of ACOs take up the challenge of ACO PC Flex within that program beginning next January. Here's the issue you have with total cost of care and total per capita cost. It's not actionable. And why isn't it? It provides no detail on what's driving costs. All you have is the generalized cost target. You can break it down by patient. That still doesn't help you. You need to be able to move that figure as an overall metric of the program, but figure out how you're going to catch the fish, which these pelicans are struggling to do, by using individual targets that will capture cost. But what is it? And why is it not actionable? Well, it includes just about everything. There are adjustments by individual value-based payment models. For example, prescription drugs may be in or out. They may be segmented to Part B drugs or Part A drugs only. Behavioral health may be in or out. Specialty services, if you're looking at a capitation that's built on primary care only, may be out. But in general, the total cost of care is measured by all of the services that comprise claims for the patients that are in the program. But they are goals. So if you really want to reach reductions through the savings of those goals, you need to be able to hit a target of individual initiatives that in the cumulative way will address the center of that target. Otherwise, your program will look like this, and there will be a lot of wasted money in tracking initiatives that don't really matter. So you can't fly by here. There is a target on the plane here, but you can't fly over cost. You really need to dig down into diagnoses and procedures and avoidable costs, low value services, patients whose risk is escalating, health equity, patients without access, which end up costing money on emergency room use and admissions and mortality. So sample of opportunities going into those diagnoses and procedures. These are just things off, any major player list. You can reduce the ER and admissions for patients with diabetes because of hyper and hypoglycemia. You can lower admissions for patients with heart failure, slow progress towards kidney failure, and lower variation in cost for your procedures. Now, are these easily done? Not with only claims data, for sure. So that's one of the things that comes up when you start looking at real cost opportunities, and how you can drill down is where the data is going to come from. But basically, you're going to have two paths to reduction of cost. One is a clinical or quality path, where you will have to use tools to identify patients who are at high risk or persistent poor control. You will have patients or ways of identifying patients with hidden diagnoses that are progressing and causing cost issues in various services. And you will have variations in the way prescriptions are applied to individual patients along the chronic care map that may help you identify financially related access as well, your health equity. There will also be a pure cost path in cost variation, where you can simply plot actual services along a line and identify the variation in those costs between providers and patients, and then dig into those through procedural episodes and treatment episodes to identify what is causing higher or lower costs. And it's really easy to see when you chart those out. The construction of episodes are not easy, however, in order to make them be filled with clinical integrity. And you will be able to identify circumstances in those episodes that will lead to higher costs. For example, certain approaches surgically, whether it's open or laparoscopic, will end up with higher costs. Choice of patients along a particular spectrum of risk will end up with higher costs, and so on. Whatever you do, however, whatever you have chosen as your target, it has to be matched by having information in order to deal with that. And here's the hunting dog looking expectantly for that information. Where does it come from? Well, obviously, if you can unlock this beast, you will find a very powerful source of information for yours. And when we look at that today, we're going to look at only what's easily available sources of data for ACOs. I mean, first of all, we've already identified claims data. You get it quarterly. You're going to respond to that by acting on and processing the claims data into a variety of analytics. It will, in order to do what I'm discussing with episodes, you will have to bring that down into a patient-centric database to do that, not just looking at categories of cost, but looking at the actual services associated with individual patients at risk to be able to identify those risks, risky, high-risk patients. Your APP measure response data is also an easily available source of data for ACOs for the first time going into APP reporting. Unfortunately, even though claims is a rich source of data on Medicare total cost of care, most ACOs do not use it to its full extent. Why? Mainly because that data is, if you were going to use it to its full extent, you would be creating a patient-centric data, and you would be analyzing this data with all of the risk features that would allow you to evaluate each patient's risk and break it out by diagnosis groups and populations. So you may have something falling out of the claims data where you can identify patients with diabetes. Do you also have the ability to identify those patients by multiple morbidity or mortality so that you can actually apply a broader base of population health and other targeted clinical initiatives? But it does have a lot of value. It provides the services, that's a big thing. It's easy to see the network gaps. You can see when your patients are going out of network for specialty services, and you can identify where they're going when they're going outside of the network for primary services, which is really important. You can identify your highest volume specialists by this tool. It enables you to calculate cost by category of service, which is not meaningless. It's important to know how you're benchmarking category of services and what your overall inpatient admissions account for, as well as your SNF services and so on. You can identify patient utilization of various services and when they're not utilizing various services, which is important. You have a type of risk score in HCCs. It's not predictive. It is retrospective, but it does give you a way of looking at patients with more events in their history. It does not tell you what is going to happen in their future, but it is helpful. And with diagnoses, you can identify patients who should be seen who are not being seen if you are combining your enrollment data along with the claims data. You can see who hasn't been seen. So what's missing in the claims data? Well, any clinical information outside of diagnosis is missing. That's important. Any predictive patient risk, meaning what happened to those patients that would indicate that they're getting worse over time. It's not capturing hemoglobin A1C. It's not capturing blood pressure values. All those are important things to be able to see if you're going to see who is in danger of running at higher cost in the future. Depending on the payee, it is difficult to identify all the specific providers because of the way Medicare is paying. That will be very dependent on your region and how providers are being listed. And then it's very, very hard to see patient status within individual conditions. Now let's look at the APP reporting data. And what you have here is a tool that can have broader reach, like this colleague can go after a full flock with multiple different initiatives. The APP data, measure data allows ACOs to do greater number of individual cost initiatives that have clinical relevance. The numerators of the three APP measures can partially fill the gaps in some of your claims data. So you can see patients with diabetes and hypertension. You can see patients with behavioral health and admissions. So evaluating the multiples that come out of the numerators of those data potentially creates a greater pool of risk for your patients and could enable cost initiatives on the clinical path as well. They may be narrow, but they will be defined by issues such as stroke risk and advanced diabetes and chronic kidney disease and so on, and pure issues of depression on admissions, which is a strong indicator for higher admissions. What's the missing information with APP data? Well, a lot of this is dependent on how you're going to fulfill the APP numerators. So if you are collecting QRDA1s, meaning you want to do this by an ECQM, it may be harder for you to get the numerator data because it will need to be processed and integrated with claims data to show the full breadth of whatever's missing. QRDAs are limiting data to a measure in which a patient triggers. So there will be a lot of missing information on that. And it is not, if the patient doesn't have the test for the A1C, for example, you won't have that information at all. So that's an important thing to understand. If you are gathering your information to report on Medicare CQMs or regular MIPS CQMs, then you will have much greater access to the actual values of that because you can collect that information in a variety of ways. The most important way would be a generalized flat file that can collect not only that measure data, but all sorts of clinical information. And in that way, you would have a greater amount. But we're looking here at the lowest common denominator of what is in the APP data, and that would be just these three measures and just provided even potentially through input methods if you're using the CMS lists for your denominator data. If an ACO is reporting Medicare CQMs, one of the challenges is for providers to get engaged in APP data as a relevant source for cost initiatives because it's not relevant to all of the business that they may be under contract with, especially the commercial contracts or practice payer agreements. So what I'm really saying there is that getting a lot of data has to be perceived as a big value to the physicians in the program as well, or there won't be any real effort to gather that data. But the fact is the more resources, the more opportunities you have to reach the targets that you've set, and so you can gather forces and work collaboratively with your providers, within the ACO, with specialty providers to reach targets. So here are the 4 areas that are just really clear that you could work with these 2 combinations of sources. One is patients with poor control in diabetes and hypertension, because you will have those numbers, and you can choose a control group of patients with poor control in each of those to narrow your focus and establish a real critical target of potentially high-risk patients to be within your ACO initiatives. Behavioral health, you could attach that to the prior group, or you could pursue it independently to make sure that you are connecting those patients with providers. Patient risk in metabolic disease as a whole, if you're collecting not just the APP numerator data for those 3 measures, but if your data collection method involves more, you can address more. And specialty care services, because your claims data gives you a lot of information for you to be able to plot that on through episodes onto a cost curve and identify what's going on with specialty care services, would be a really good target, since it's such a huge percentage of your overall cost. So what's in the easily available data? Well, you've got the patients with diagnoses, you've got APP measures with risk values, you've got the various pieces of data on the clinical coming through the APP side to provide trend and control values over the year. So you can see whether patients are getting worse, staying the same, but in a problem category, or they're improving. Patients with the most problematic values, and you can see that the claims and events, along with other EHR data, could show comorbidities that can increase your risk. So I'm going to take a couple of these and just go through what a process would be to establish an initiative based on that. So here's diabetes and hypertension. You've got your 2 claim sources, claims and APP measure data. Let's say you're just using the measures that are available out of those 3 measures, and you're not collecting any other clinical data. So your data-driven strategies would allow you to create a high-risk pool of patients based on diagnosis and A1C and blood pressure values. You could also include in that any events that you find in that patient's history from claims, admissions, ER use. Hyperglycemia will show up as a diagnosis, so will hypoglycemia show up as a diagnosis category that you can add to your risk pool in here. So that would be an additional risk factor. There are others too. For example, a diagnosed stroke would be a risk factor. Clinical review, referral to specialists, patient programs can come out of that as actual interventions that would allow you to take that group of really high-risk patients and start to move it into a lower risk category with lower cost of services. Behavioral health, again, those 2 data sources, you would be able to create a pool of patients screened with depression and no treatment plan. You can add additional risk for diabetes and hypertension because you have that data from the APP. You can pilot or use your community referral providers for follow-up on those patients and establish an ongoing risk evaluation monitoring via population health. This dog is playing fly ball. He's ready. He's at the end of the target and he's ready to take off. And I think that behavioral health is a really good spot where very few organizations have tackled it, and very few have created tools in their primary care practices to help hone in on this. And primary care physicians, by all accounts, are very uncomfortable really discussing behavioral health. So there's a lot of initiatives out there that are interesting if you have just this basic minimal data to start with. And then on the specialty, so hold the wild horses on this one. Your data sources can be as easy as claims, because what you're really looking for is the creation of procedural episodes that span one procedure type. So you're looking at gallbladders, or you're looking at bariatric surgery, or any number of for example, your colonoscopy screenings can be on this. We discovered a colonoscopy screening, a screening colonoscopy, not diagnostic, for one patient that was in the $200,000 range, because the patient was selected and probably shouldn't have been to meet a measure. Prior instances of sepsis, chronic kidney disease. I mean, it was just a mess of a history, and not worth it unless it was a diagnostic situation. Using episodes will allow you to do this cost variation analysis and feed that back to your specialists so that they can review it. It's really important because they don't ever get this kind of data review themselves. So sometimes it's a real surprise to them to see it. And specialists, especially surgical specialists, tend to be very interested in going into the depth of data and understanding what really happened there. And you may get some really important feedback about your patients and clinical improvement programs that you can work over with specialists. There should be notable observations in this kind of data. You can see when you've had do-overs or complications or readmissions, and you can see why, because they're listed in the diagnostics of the claims. So you would be able to identify those for your specialists and start going after issues like that, that could have issues related to the way that the patient presented, or from other things about the patients that need to be part of your risk analysis for that patient and improvement plan. Data sharing obviously is a huge component of work with specialists. You need their data, they need your data. And it's a ripe area because specialists are really looking for data right now. They are under the gun also, and they know that in a lot of these value-based care arrangements, they are going to be at risk themselves. All of these activities will help you establish a referral program that can improve your cost for specialty care. So the strategies that you can target by data overall include episodes of care analytics, cost variation, risk assessment. The more risk information that you have, the more you can create algorithms that will identify patients before bad things happen rather than retrospectively. It can work in your health equity arrangements. It can help your physicians become very engaged in the clinical, because it's clinical. It's not about cost. It's not about benchmarking their services. It's about helping them improve their patients and in supporting them in their treatment plans. Population health, data sharing, and then of course the interventions I've mentioned. Specialty referral, medication improvement is one of those really striking things that is clear when you start looking at diabetes episodes, when you see a lot of patients who are very poor control and they're only on insulin, and it's most likely a financial affordability issue that needs to be worked. And then of course the clinician treatment review, making sure that the clinicians have this feedback so that they can evaluate their own cases. So at this point, what I really want to know is, what is your plan for going forward with data? Are you planning, number one, to use mainly claims data And here's the doc. Are you planning to elaborate that with EHR data, number 2? Or 3, none of these, it's just nonsense. Garrett?
Okay, so we have pulled up the poll for you, and the results are coming in. And just like before, I'll mention that if any of you are joining us now, this is all anonymous, and we'll show the results here. So just to give you kind of a better feel for how you stack among your colleagues here. And we've got, I would say, most of our responses coming in, but we still have a number that have not responded yet. And this would just be, of course, just to choose one that most applies. And I think most of our responses have come in. So I'm going to give it about 10 more seconds and then we'll close it down and we will show the results. And 5, 4, 3, 2, and 1. Okay, so the results are for use mainly claims data, we have 39%. For aggregate EHR data, it's 55%. And neither stop the nonsense is 5%.
5% for the platypus?
Right.
All right. Well, I admire the group for being brave and going for the peacock. There's nothing wrong with claims data. I think that you will see why it will be important as you go through the next few years and why you will probably want to be the peacock. And let me add to that. So I'd like to just spend a couple minutes at the end here talking about the future of cost measurement in this kind of now more barren land. So the CMS MIPS program, for those of you who have a background in that, has a totally different cost measurement than ACOs have. So, there's no like general benchmarked expenditures. It's broken down by individual cost of care measures. And it comprises 30% of the total MIPS score, which is just pretty hefty. And it is measured, as all things are measured, by the aggregate spending caps. But there are also 27 episode-based measures for selected diagnoses and procedures, which I think is important because this is CMS, and they are including this in the MIPS program, and every year there are more cost measures for diagnoses and procedures. And they calculate them. You don't get to see the detail of that data. And then they plot you in with respect to others. And then your MIPS score comes down. So it's hard for me to see how that's going to be different in the future. I don't think this is a penalty because providers are in the MIPS program. I think there's a growing understanding, even though the overall initiative gives a lot of freedom to ACOs to develop costs in a different way through, population health and coordination of care and so on. But eventually, they are looking at individual targets for how that is effective or not. I think it's likely that we will see some of that around specialty cost measures for use by ACOs in negotiating a global cap. If CMS is successful in pulling ACOs into the ACO PC Flex program, those ACOs will most likely be negotiating a global cap, just like ACO Reach can negotiate those global caps. And that engages the specialists in a need, and the ACO in a need for evaluating what does specialty care look like, and how do we measure it, and how do we bring it down in cost and get better quality for the patients or better outcomes for the patients. So I think this is kind of a given in my mind about which way this is going to be going. The focus on cost of specialty services is only going to increase. When you see numbers like 7% of total spending is primary care, and the rest of it is specialties and other services, it's going to be heavy the more pressure there is on the Medicare program to control costs. And the more ACOs are in that global cap, the more they will also want to guide the distribution of those dollars to specialists who are going to save money and be engaged in common strategies around data. So what has to happen in order for us all to get there is that ACOs have to grow their data expertise and knowledge of how to work with that clinical data that they don't look at right now. They need to help providers move to systems where it's easier for them to aggregate that data. That's going to be, I mean, we sit in the seat of aggregating clinical data from all practices, and it's not easy when you've got small practices on very old systems. They're not certified systems, and they don't have easy ways of getting that data. So there's going to be an urgency about helping providers move to common systems or fewer systems that are selective and will play well with the ACO in gathering data. As natural language protocol grows within EHRs, it will also unleash a huge data surge. We will find diagnoses that have been buried, and we will find health equity issues that have also come up in conversations but never coded because they came out of the practice setting in conversations between the physician and patient. And then you have genomic data. I mean, now we're looking at treatments that just a few years ago were unbelievably impossible to imagine. And it's becoming available because the cellular biology is driving it to become available. So all of that information must be digested in some way by ACOs in order for them to be relevant on how they can control costs and move better outcomes in the future. So ACOs are going to have a choice on data. They can, you can choose to stay out of it. You can choose to have a million targets and arrows coming at them from all directions. But your choice will also have the consequences of kind of not productive, not a growing landscape, although many people believe the desert is a landscape teeming with life. It is not with a life like we necessarily want to see it. So that's my take on present and future, and I hope you have some questions for me.
Okay. Yes, we do have some questions. And first of all, Terry, this was a fantastic presentation. Thank you. And for those of you who are listening, obviously there's a lot here. There's a lot to consume and absorb, but don't worry, you'll get a chance to do that because we're going to afterwards, we'll send out a link to the recording and where you can download the slides. But for now, if you have a question for Terry, Go ahead and drop it into the question box there in your little module, and we'll get to as many as we can. So, but let's start with this one. Uh, why do you think it makes sense for ACOs to look at cost variation of specialists if specialists are being paid by Medicare, not the ACO? What difference does it make?
Well, the specialist costs are in your savings formulas. So that's one reason why it makes sense. Also, I think the question assumes that specialists would not want to be part of initiatives to lower costs. And I don't think that's the case. I think that specialists simply want to have the clinical autonomy over patient care in their designated areas, but they definitely are interested in trying to collaborate and make sense out of costs themselves. So I think it's a valid question, but I think it assumes the question that specialists might not care about cost. And I think they do.
Yeah. Okay, next question here, and this may be related, but what about ECF expenses?
ECF expenses.
Hmm.
Hmm.
Do we need
What
our asker to expand on the question? If you want to resubmit that question, we'll see if we can expand on it a little bit. We're working live here, folks. Um, all right, next question here is you said TCOC and TPCC are not actionable. Can you explain more why you see it this way?
Well, because when you take a total cost of care, what are your options for it if you have nothing else? Uh, I guess you only have two options. One is prohibited, which is denying services to bring it down. Um, Having a prior authorization system that is essentially punishes cost. And the other one is to simply benchmark providers and tell them what their cost targets are and expect them to meet it. And that has the same effect. Maybe it's assumed that that will motivate them to meet benchmarks. But what is the direction of the actual patient care? It's something you don't really know. So I don't think it's actionable unless you actually go into clinical types of care and patients and identify strategies that are going to help you lower the total cost of care in a way that is not simply meet X. It's like I used to once manage a lot of billions of dollars of healthcare services, and I would go up against budget committees. It'll be obvious what this really is about going after state budget committees. And they said, "Why are you spending all this money on typewriters?" It's a long time ago, obviously. Or look at all this travel that's going on. Why do you guys need to go to Chicago? And it's because when people can't understand what's in a large amount of money, they go after what's simplistic, easy, and one-time solutions. In order to have solutions to cost that keep the needle moving towards lower cost, you've got to get at what the costs are about, which is patient care.
Great. Okay, we had a little clarification of our earlier question come through. Uh, but it says, I understand that ECF expenses, and I'm still not sure what ECF stands for. Do you know that, Terry?
Nope.
Uh, could you please shoot that over to us? But let me go ahead and read it. I understand that ECF expenses can be as much as 20% of the total spend on Medicare patients. Isn't that a significant part of total spend? If I'm responsible for total patient spend, I might want to look into the ECFs that our patients are being referred to. I wonder if that's extended care facilities, perhaps?
Oh, yeah, yeah. Yeah, I think that going at that is something that ACOs have done from the very beginning with claims data. They've gone after SNF care, they've gone after referral arrangements, and who are making sure that people are not kept for the full amount of time because it is allowed by Medicare claims. But that is a one-time savings, pretty much. Once you take the money out of wasteful spending, the wasteful spending category, and not the clinical spending category, then you've got that strategy in place. Your total spending drops. You never can repeat that. So it's not renewable savings, if you know what I mean. It moves you to a lower level, but it doesn't have legs. So I think it's an important strategy. Find the waste, find low value services, get rid of those. They they will not have the power that changing the risk of the patient and the trajectory of that patient will have over time.
Great. And I appreciate our audience. People were sending in all kind of different suggestions of what ECF, but we got it. So I apologize. End of life care, extended care, but yeah, I think it's all surrounding the same thing. So sorry to put you on the spot like that. Uh,
It's okay.
last question here that we have at the moment, unless another one comes in, is how important is the timeliness of the claims data?
Oh gosh, that's really important. Um, well, it's important always to understand that your claims data is always retrospective. And so you are never dealing with predictive risk and you are never able to manage predictive risk of that patient. But the longer it goes, the less opportunity you have to even do anything with the data. So if you're dealing with admissions that took place 3 months ago, then, or even 5 months ago, because they're not always billed the same time that you get them either, is uh, is pointless. That's why you really need the clinical data to enhance. And I think the APP gives an extraordinary opportunity because it is so focused for ACOs to really look at how they might do that. So many paths there, so many.
Yeah. Well, very good. Well, that was a good question to end on, and I'm sure there's more in your minds out there, and maybe they're not even developed yet in terms of what question you want to ask. That's okay. We're going to have two more of these webinars. This is again the part one of a three-part series, and so what's going to happen is uh, we'll be sending out, of course, a link to the recording today and the slides, but then also a link to where you can register for the upcoming parts, and hope that you join us for part two and three. And but thank you, Terry, so much for this. This was a wonderful presentation. Again, there's a lot here. And hope to have you all also come and visit the virtual exhibit booth for Roji Health Intelligence at VBC Exhibit Hall. So if you go to vbcexhibithall.com, and you'll be able to see there's a lot of resources there, but you'll be able to visit the Roji Health Intelligence exhibit booth, and there a lot of great resources. You can read up on them, what they're doing in the space, and really educate yourself on that. And there's of course ways to reach out to them as well. And then finally, if you would like to reach out to Terry directly or to the Roji team, feel free to do that. Their information is here. Leonard is their business development guy, and a great guy, and be happy to field any of your questions. So if you wanted to reach out to him, his information is here, or feel free to reach out to me. I'm happy to facilitate an introduction for you if that's easiest for you. But thank you again all so much for braving the weather. I know there's a lot of like nasty weather going on across the country, and I've seen a bunch of people come in and out and come in and out, and I think it's probably some of that power stuff going on. So appreciate you sticking with us for that. Hope to see you on the next one. Thank you all so much for joining us. Have a great rest of your day. Bye bye.